Okay, so we've checked out the joint following the Kaltenborn-Avianth model of examination of observation, active range of motion, and then looking at joints specifically, AC, SC, GH, and now we look at selective tension testing, modeled after originally James Syriac's, and then the Kaltenborn-Avianth people have certainly picked it up. So if we think about the different muscles crossing the glenohumeral, then we're going to try to select these tests in a way that through inhibition, we can isolate a structure to help point us into the direction of where and what we suspect we should then eventually palpate. So listen to the way I said that. We had a whole scheme that we followed: observation, active range of motion, joint glides, and then selective tension. And then we're going to get into some very specific palpation after we finish this part. So what I'm going to do first is I'm going to say that we have a suspected structure on her left side. I'm going to ask her to resist me with the elbow at about 90 degrees and the shoulder at 0. And then I'm going to position myself so that I can overpower the patient. So I want to find out what a maximal resisted test is in a very subtle, careful way. What do I mean by maximal? I mean her maximal, not mine. So it's when I feel the patient's hold that I'm asking them to perform gives. And I'm very careful about how I build up to that. I try not to have anything ever done abruptly. So I say, feel how your elbow is not touching your rib cage. She acknowledges that. And then I say, do not let me push it towards your rib cage. And then I'm using my body to take her to the point where I feel it gave. Okay? And you probably couldn't see much from where you are sitting or standing because there wasn't much. I'm trying to do this without motion. So when I have a small therapist and a large patient, this could be done in side lying, Micah, so that the patient could be then in a position that the therapist could have total control over with their body weight. So there's only one patient I've ever had where I couldn't do this, and he was an extremely strong person. But everybody else, I could be here, and then I'm pushing off my legs, and I'm not trying to resist her with my arm. It's my body coming into her very subtly, so it's my legs that resist me, pushing in like this. Okay? So everybody here should be able to do it. Sarah should be able to do it to Logan.
Okay.
Okay. So then I'm saying, any change there? She said no. Okay, so the next thing, if that was supraspinatus, and it could have been deltoid, and it could have been infraspinatus, could have even been upper fibers of subscapularis. Anything that would pull the shoulder into a position where it slightly abducts. So to rule out whether it's supra or infra, I would have her shut down the supra by having her adduct. So I say, feel my fist against your ribs. Don't let me pull it out the back. Good. Now hold it there. And then just so she can see, I say, do not let me press your wrist toward your abdomen. And hold. And then we slowly build. Look where my own arms are against my body. So it's my feet where I'm pushing off to produce the give. So I was like this, and I was doing that as opposed to having a contest between her arm and my arm. Okay, so if that was negative, then I'm going to get out here and ask her to hold, and I establish a contraction just enough that I know she is abducting. Okay, now if she's abducting, that should shut down pectoralis. And now I'm going to ask her to hold, and don't let me pull your wrist from your abdomen. And then again, look what my elbows are. I then rotate my body on my feet so that it's a resistance of internal rotation for her to the point that she gives. And it starts very slowly, gradually, so she can report to me as soon if she feels some symptoms. And we don't go beyond that. Symptom reproduction is enough. Then I look at other structures that could follow off the shoulder, and we have biceps. So I could do straight elbow flexion, and then to look at biceps, I would then resist supination as well. So I have my carpal row against the ulna, and then I say, do not let me press the little finger side of your hand down to your thigh. And then it's me against body weight. Okay, so the emphasis was on the ulna, pressing down this way. Okay, to look at deltoid, if it was painful with abduction and it was not painful with the infraspinatus, then I could take it here, and then I would look at the anterior and posterior fibers and say, hold, don't let me push it forward, and don't let me push it posteriorly or backward. So if that caused pain, then I'm suspicious of the deltoid tuberosity down on the humerus. Seldom. I can think of one in my career that it was deltoid. Okay? When I first came back from Norway, everybody suspected biceps. Okay? In our testing that I brought back, supra was more involved than biceps. And so biceps finally, fortunately, fell out of favor, and people could see that it was more specific supraspinatus. That would be a rotator cuff tendinopathy or infraspinatus. And then for the internal lesions, it would be subscapularis. Okay, so now if they are positive on any one of those tests, it would be coming time to palpate. But perhaps I'm getting ahead. Maybe we should just do these first. What do you say, Ashton? Okay, so to review, we're going to look at supra, and we're going to ask her to hold. Don't let me take your elbow towards your abdomen. Good, and that just to the point of breaking. Then if that were positive, I still don't know if it's coming from supra or infra, so I'm going to ask her to adduct, and then that should shut supra off. Understood? Now, we're not done yet. Now, do not let me push your wrist toward your abdomen. Okay? And then if that were positive, that would indict infra. Okay, now, say she was negative to both of those. Then I have to look at sub. So now I ask her to abduct, shut down pectoralis, and then hold, and don't let me pull it out. Okay, if that were positive, then I would suspect sub. Now, she could also have pain with elevation, and she could have been negative to supra and infra, so then we'll look at biceps. Hold here. I put my carpal row against the ulna, and I say, hold. Don't let me take your little finger side of your hand down toward your thigh. And then we gradually take it down, and it gives. At that point, if that were positive, then I would suspect biceps. Triceps, I've never had one, but you could easily resist in the back, and then hold here. But if it's in the back, it's more commonly infra. All right? You want to repeat those? Say yes, I'd like to do over those. Okay, what? Oh, deltoid, sorry. So we're going to eliminate the middle fibers of deltoid because that could be supra too, right? So then I'm going to look at the other aspects of deltoid, which if it's deltoid, both of those should be positive. So it would be horizontal ab and ad. Okay? Hold, don't let me push your elbow forward. And don't let me take your forearm backward. Okay. Now, I'm going to call an audible, and we're going to add a couple. If you're dealing with athletes, you may have to put a more aggressive test for infra. And so, like pictures that we've had here, we used to have a lot of minor league pitchers that would come home for the winter and they've thrown their arm out. And so I could ask her to adduct here, and look where I have my elbow positioned. And then I ask her to don't stop early. And then I say, hold, do not let me push your wrist forward. So this is a more aggressive test for infra. Okay, and then we could have a similar, more aggressive test for sub. Hold here, and I'm resisting abduction, right? And then I say, don't let me pull your wrist backwards. As a therapist, you want to make sure that you do not let up on these muscles that are to inhibit the first. So on this one, as she clinches in, I'm leaning back so that she has to clinch in. And then I add this one. On these, the therapist sometimes will say, hold, and then don't let me lift it. And then when they do this, they forget about the continued lift they have to maintain in order to isolate the supra out of the question. Okay, and then we all have the famous empty bottle. So she's hold here. This is our problem side, and I ask her to hold the good side first, hold, and I build the contraction, and I feel where the give point is, and then I ask her to do the same on this side as I add the right to the left. I did not let go of the left. I brought it to the breaking point, and then I started building on the involved side, her left, and then we took it to see if they were equal in their breaking point and strength. So in this classification, Syriacs would say if they had a full contraction but painful, he would describe it in his note as a minor lesion. If they had a contraction but it was weak, he would consider that a major lesion. If they had no ability or no power to call, he would suspect that to be an avulsion of the tendon, and other tissues may be compensating. Okay, one other point I forgot to make. It is seldom that they would be positive on every test unless the whole thing were inflamed, like going through adhesive capsulitis inflammation. In that case, you would palpate underneath the acromion to the subacromial bursa, because it can be irritated, and if it's irritated, then that's a whole different treatment regimen that we would do differently than if it's a tendon and what you're treating. So you'd treat a bursa much different than you would a tendon. Okay, so if this is tender, right versus left, and the left one's super hot, then that suggests a bursa problem, and that's a whole different treatment than what we're going to get to in the next few minutes. Okay?
How do you know that's a bursa and not the tendon?
What?
How do you know it's a bursa that's irritating and not a tendon?
If all the tests were positive on them, the bursa would get irritated with all that testing. So it's seldom that a rotator cuff problem would involve every rotator cuff. Okay, so if every rotator cuff test were positive, then I would palpate the bursa, left and right, to see if it was sensitive. Okay, then you as a therapist, if everything on you they do is painful, then you might have to look at local presentations. Or excuse me, on fundamental factors, the last one. What does it say? Read it, Emily. Fundamental factors.
The last one.
Altered.
Altered mental, emotional, physiological, and neurologic processes, sensory perception or integration issues, autonomic nervous system.
Yeah.
Yeah.
So then we have another presentation that we as a therapist have to manage that we're not talking about right now. Right now your job is to do selective tension testing. But there is that type of presentation where everything is painful. And then you're going to go into that management scheme there, which is a different animal. One that we treat though. We don't let them get out the door because we have something to offer them that can help and bring them around. We have a lot to offer. Okay, any other questions on this subject? Okay, why don't you get with a different partner than you did starting out today, so just to mix things up a little.